Started, guys. We're at Oxford Civic Center with the Oxford Fire Department. Thanks for having me out here. I really appreciate it. We second floor, if in the area, come out. We got lunch coming around 11 and have skills lab with the docs today. I also got survival flight 16 coming in, but we'll do some advanced airways, some mega codes. Got the ultrasound trainer, can't do surgical airways. There's a national shortage of pig tracheas and sheep tracheas for some reason. I'm not sure how COVID affected them, but obviously it did because I can't get them anymore. So life is weird. So we'll get started. I'd like to thank the fire college as well. Without those guys, we want to be able to hit the road and do those skills labs. I think that's probably the most important part. Get to meet some of the docs that you're kind of working with at times. So for those that are unaware, EMS Challenge, we started back in 2014 to bring more physician involvement into pre-hospital education. It seemed like when I was doing pre-hospital stuff years ago, there were docs involved, and that seemed to kind of wane a little bit. So the goal of this is to bring more physician involvement, kind of rebuild some of those relationships. For your certificate today, look at the blank screen as it flickers. There you go. I like that. That's good. Those of you in here can scan the QR code. If you're online, you can use the chat box and get that going. Is this what I was doing earlier, Chief? All right. High tech. All right. We got some events coming up. The state EMS conference is the second week of November. The SMEC meeting is that Monday. There's a town hall at 10, and then the meeting's at 1. So if you're in the area for the state conference, come to the town hall meeting. We'll be presenting Wednesday. EMS Challenge. We'll do a kind of cardiac lecture, and then Dr. Brown is going to talk about cyanide and carbon monoxide poisoning, I think. And that afternoon, if the pigs and the sheep trachea show up, we're going to do surgical airways as well. We're going to be in Springville in December, and then starting after the first of the year, we have either February or April going to be at Talladega Superspeedway at the track doing the EMS Challenge. And then Birmingham Fire's a big supporter of us as well, and we'll be doing the second Wednesday of each month. We're going to have 6 of those at Station 2 with Birmingham Fire as well. And as soon as we get our screen up and going, we'll keep going. I can tell inappropriate humor, but it is. Okay. Yeah. I'm not sure what it's showing. I'm not online. Okay. We'll get going in a second. Who's doing a 48-hour shift today? Anybody doing a 48? No? You said you pass? Yeah, very good. Okay, that's good. Anybody work last night? One person, good. All right, good. The only 2 smiling in the whole classroom are the guys that worked last night. That makes me really uncomfortable. I'm not sure what that means about the day. Yeah, I agree with that. Biscuits are good. Biscuits and monsters. There we go. Ah, you jinxed us. So close. I'll turn the mic off for a second, Chief. We'll keep on moving. So just a couple of refreshers. Normally on the second Wednesday, we do kind of review for the region. I know we're out of our region now. Thanks, Mr. Blue, for having us as well. But remember, airway management is pretty important. It's one of the reasons people call us. As EMS providers, we should be the gurus of airway management, from simple maneuvers up to ET, intubation. For years, the nasal and oral airway have been used. Folks kind of going away from the nasal trumpets. They're still a great way to give somebody a simple airway if they got trismus. It's also a great way to oxygenate somebody. A nasal trumpet with some O2 by nasal cannula or O2 off your ambu bag placed in there really oxygenates people. One of the benefits that we got from the COVID pandemic was that we realized that nasal cannulas can provide a lot of oxygen for people. And we'll talk about some passive O2 when we get to the skill labs today. Blind insertion devices. Remember, if you're using blind insertion devices and you're a paramedic, you should have waveform capnography. If you don't have waveform capnography, something ain't working. If you're practicing at the EMT or advanced EMT and you don't have access to waveform, hey, no harm, no foul. It is what it is. But just food for thought, and we can play with a lot of the stuff here in a little bit. Remember, for intubations, you got to have waveform capnography. You got to see a waveform and have a number. My advice for you is in your documentation, your narrative, put that you see the waveform and put the number down. I know a lot of the code stat, the summaries switch over. Sometimes those things don't link up, but I'm telling you from a medical legal perspective, if somebody's reviewing that chart and they see in the narrative that you placed an ET tube, that you visualize waveform capnography and you put a number, and the issue is airway, that person reviewing that for the legal side is going to be done with it. You're covered. It just keeps you out of trouble. All right. So document waveform and the number when you place the tube, and then when you're done, whether you're transporting over to a flight crew or at the hospital, or if the patient is dead and you pronounce them, call it on scene. Put your last numbers as well, that you got a waveform and what number it is, and it keeps you out of a lot of trouble. Anybody using the Easy Cap, the litmus papers for intubation? So those are reasonable too, but standard of care, if you're ALS 1, if you're doing paramedic level care in the field, is a waveform capnography. I like the Easy Cap. It's quick and easy. You slide that on there, give it a few breaths, you get a color change, and then somebody's grabbing the capnography to put it up for your waveform. But I can tell you right now, you're better off pulling a tube, using simple maneuvers, bagging somebody, than leaving a tube that's in the esophagus. And esophageal intubation is unrecognized, nobody survives from. Okay. Just some friendly reminders, 12 leads early and often. Remember, the hospitals are starting to like our data from the pre-hospital side. If you're able to give them a time that you get that 12 lead in the narrative, so 12 lead at, 9:10, and then put STEMI or no STEMI. All right, they really appreciate that documentation, and that's giving us some power to kind of get feedback on the hospital side. Some of the heart centers can only reimburse if they meet certain metrics. They can only get the money back from Medicaid, Medicare if they meet certain metrics, time metrics, and documentation metrics. And EMS numbers are required for that now. So we have a little bit of power over them to maybe start getting some feedback. We talked about capnography, epi. Are y'all having any trouble here getting epi for cardiac use? Epi 1 to 10,000 supplies? No. I know some places are still having some trouble finding some epi. Epi dosing in cardiac arrest, first dose epi as quick as you can is paramount. Second dose epi kind of depends on what's going on. A lot of places are stretching out to 5 minutes. I know in some parts of the country, they're going to do the first dose epi and hang an epi infusion. Put a milligram of epi in a 200 bag, 250 bag of saline and run that wide open. I still think first dose epi in cardiac arrest is pretty important. Second dose depends on what's going on, and we'll play with that in the lab today. Narcan, remember the goal of Narcan is to make them breathe, not make them wake up, call you names, crap on your stretcher, or PRT, okay? So if they're breathing, they probably don't need Narcan. There are a lot of folks using opiates and other drugs, and you give them something that reverses the opioids, you can actually make them more agitated, they get nauseous, they can vomit, and still have loss of airway because they've been doing their benzos, their Xanax, their alcohol, their spice, whatever else they got. My other advice on Narcan is nasal Narcan does not work if they're in cardiac arrest, right? So I've reviewing some stuff from the region. I've seen a lot of nasal Narcan in cardiac arrest. First drug of choice after ABCs is going to be epi, and it's going to be IV, not Narcan. Anybody else can Medrol here yet? Have y'all purchased Medrol? Some folks, yes, no. Somebody's maybe making eye contact. Thank you. I appreciate that smile. Good. So Solumedrol is a great drug. Remember, there's some risk to it. The biggest risk would be in diabetics and for pregnancy. My advice on the Solumedrol use, if you're using that for anaphylaxis, you've already popped them with some epi, yeah, they get Solumedrol if they're pregnant or not pregnant, or if they're diabetic or not. But remember, Solumedrol in pregnancy can really jack up the baby. It can also increase glucose in diabetics. But if I got somebody that's severe COPD, asthma exacerbation, in my mind, I'm thinking they're sick, high risk of decompensating, dying in front of me, they get the Solumedrol. Same thing for anaphylaxis. Toradol is a great non-opioid pain medication, but there's some risk to the Toradol. Remember, if folks have kidney problems, you can really damage their kidneys long term. So people over the age of 60, people that are pregnant, people with kidney disease do not need Toradol. And my advice would be cut the dose in half based on what the protocol says. So I would do 30 at the most IM and 15 IV. More than that, you kind of pushing damage in somebody's kidneys, okay? So not so friendly reminders. There are attorneys, law groups out there that are looking to sue us for airway management issues and advertising for bad ET tubes. So again, I cannot stress enough, when you manage an airway, make sure you document that you manage it well. If you put a tube in them, an ET tube, you got to confirm it's in the trachea. If there's any concern it's in the esophagus, pull it. No one lives with an esophageal intubation. If you practice long enough, you will tube the goose a couple of times, but you should recognize it immediately thereafter and pull that tube. Sweet. All right, on to some EKGs. All right. So for those of you online, I know you've seen me talk about EKGs a lot, but I think it's pretty important. The machines are not correct. The reps say that the machines interpret the EKG about 90%, and I would say it's probably less than that, a lot less than that. So I look at 12 leads pretty simple. They're a screening tool, and I think about it as a too fast, too slow, or okay. American Heart, I still like. Too fast should be either wide or narrow, regular or irregular. That's the pathway you go down. Too slow, the three things that cause you to be too slow, that's drugs, electrolytes, or ischemia, right? Anything else you can pick up on your primary exam. The 6-month-old that is blue, breathing 2 times a minute with a heart rate of 50, what's their problem? Breathing, yeah, duh, right, yeah, they're not breathing, they're blue, they're hypoxic, so they're gonna be bradycardic. You pick that up on your exam. You should be managing that airway, aggressively ventilating them, providing some O2. Heart rate should get better. They don't need IV drugs or medicines up front, right? The 30-year-old dude shot in the belly that's talking to you when you get on scene, heart rate's 120, and route to the hospital, his heart rate goes to 90 to 70 to 40. Now he's altered. What's going on with him? Yeah, volume loss. He's dying, right? Hemorrhagic shock. You don't need an EKG to figure out why he's getting slow. But these three things you do. So the drugs would be beta blockers or calcium channel blockers, things that a lot of folks take in the South for hypertension. It could be an intentional overdose, or it could just be that they've been on too much meds for too long, and now they're older, the body's different. Maybe their kidneys are having some issues, they can't clear that. Electrolytes should really be electrolyte, really. What electrolyte makes you get slow? Electrolyte, yeah. What electrolyte can jack up an EKG and make it be slow and wide? Potassium, yeah. So hyperkalemia, right? If you miss that, people die from that. And then the third big cause of bradycardia is ischemia, right? So the STEMIs and the NSTEMIs, right? I use a rate of 50 to 140. 50 to 150 is my normal in-between rate. So that's the okay-ish there. And those are where we got to determine if we're having STEMIs or not STEMIs. But you can pick up other things. You can pick up infection. You can pick up certain kind of drug overdoses. We'll talk about some functional use of AVR, okay? So this is the way I look at 12 leads. Make it super simple. Too fast, too slow, or okay. And I manage right there on scene. Try to stabilize them. So things you got to calculate as a rate on paper. Again, do not trust the writings on the top of your 12 lead. The numbers, the math, it does fair, but still have a way to figure it out. And I know what you're thinking. You just look at the monitor and read the monitor number, right? Yeah, I got it. But if you're looking at the paperwork, you got to know how to calculate a rate. I use the box method. So one box is 300, then 150, then 100, then 75. Then my ADHD kicks in. I start thinking about fishing or drinking a beer or going somewhere. And when I wake up and look up again, they're way too bradycardic, right? So have a way to do it. There are different methods out there. I like the box method. I can memorize that. Intervals, you got to know your intervals. So PR interval, What did y'all learn about the PR interval in paramedic school? What's the importance of a long PR interval? Anybody know? Anybody care? Nobody cares. First 3 heart block. Yeah, so prolonged PR is a first 3 heart block. What do we do to treat a first 3 heart block? Nothing. Yeah, it's like roll tide, right? Nothing to do with that, right? Yeah, but a long PR in a bradycardic rhythm that's got a wide QRS is classic definition of hyperkalemia. So knowing these intervals is important. If you don't know what a wide QRS complex is, you'll get messed up and think that that VTAC that's just a little wide is SVT, and they're treated way differently, and people can die from that. QR interval, QT interval. Why would that be important? What's the importance of a QT interval? If you have a long QT interval, sometimes you get something called ROT, and it causes a dysrhythmia called, I can't spell it for sure, I can barely say it, torsades. Yeah. So long QT leads to torsades, and people die from that. All right. There's some drugs that you guys carry that prolong the QT interval in patients already. So if you got somebody with a long QT interval and you give them one of those drugs, you can make it even longer. And they go from, feeling bad, looking sick to going into cardiac arrest. It's pretty cool. You get to do things. You get to pump on the chest and shock them and stuff, but it's poor form, right? What drugs do y'all carry that prolong the QT significantly? Anybody know? Zofran, yeah. So Zofran, you can give somebody 1 billion milligrams. That's a joke. Don't do that. Sorry, let me rephrase. You can use Zofran pretty judiciously with patients, all right? And most of them do fine. But if they have an underlying long QT, there's a risk to make them having torsades. What other drugs y'all carry prolong the QT? Anybody still carrying Haldol? Yeah, so Haldol prolongs the QT. Benadryl prolongs the QT. People that are high risk for having prolonged QT and high risk for having torsades are folks who have malnourished, chronic diarrhea, alcoholics that have low MAG levels normally, right? And then anybody on an antipsychotic or depression or psych medication, all those drugs prolong the QT. So those are things to think about. Cool. All right, so this one, too fast, too slow, or okay. Machine says 70, but we're not supposed to look up there, right? So I'd say the rate's going to be 300, 150, 175. So yeah, it's fine. Yeah, rate's okay. So the next thing I do is I look at injury patterns. Now you can talk about vectors and things of that nature on 12 leads, but there are days I've been up way too long and I get confused with vectors. So I have the same approach to every EKG, so I don't miss a STEMI at 2 in the morning when I've done my 5th 12-hour shift, right? So I look laterally. I look 1, AVL, and 5 and 6. I'm looking for ST elevation or depression. If I got ST elevation in any 2 of these 4, it's a STEMI. Diagnosis made. We know what we're going to do. Okay. The next thing I look at is 2, 3, and AVF. These are your inferior leads. Same thing. I'm looking for elevation in any 2 of these. Next place I'm going to look is V1 through V4. These are your septal. That's V1 and 2. And anterior 3 and 4. Elevation here concerning for a main part of the heart going down the middle, septal or anterior. You can also look at V1 through V4 for ST depression and T-wave inversion. And this means it's the posterior, because if the V1 through V4 look at the front part of the heart, if you flipped it over, it's the backside. So depression in V1 through V4, any 2 of those, that's a posterior STEMI. You get some people that want to be kind of academic-ish. If they see that, they want to move those leads over and do a posterior EKG. Anybody ever done that? Good. I like that. Me neither. I don't like them. Yeah. Way too fancy, too much work. We got a sick patient to take care of. From a diagnostic procedure, if somebody's got this, I'm treating them like a STEMI. I'm talking to the cardiologist, and the only person who's going to back me down from that is the cardiologist. The last place I look is lead AVR. All right. So classically, we were taught that if you're up in 1, you should be down in AVR. That tells me my leads are on correctly. In reality, AVR gives us a lot of information. ST elevation in lead AVR and depression anywhere else, inferiorly or laterally, is a sign of a left main disease or right main disease. Okay? So elevation in AVR and depression anywhere else in the right patient is what we call a STEMI equivalent. And that should see a cardiologist. Now, some people, older folks who have underlying heart disease, if they get septic or shocky, the blood pressure gets low, the heart rate goes up, you'll see that EKG change. They'll slowly go up and get ST elevation and lead AVR, and they'll get depression in 1, AVL, and 5 and 6. It's called a strain pattern. And if you fix the underlying problem, that gets better. If you fix the underlying problem and it doesn't get better, it means they probably threw a clot or something, and now we have a STEMI going on. But I can tell you right now, machines are not going to pick that up. Sweet. Once I go through all my injury patterns, I'm going to go back to lead 2. I'm going to look at my intervals. All right, so my PR interval is reasonable, QRS is wide, QT is normal. All right, and if that's fine, what I do is I go one more time for injury patterns. I look at it twice before I put it down, so that way I don't miss anything. Now, if my QRS is wide in lead 2, now I got to go over to V1. Now I'm looking for bundle branch blocks. That's about as deep as I think we really have to go for the ER or pre-hospital, right? So bundle branch blocks kind of change things. It changes how you interpret V1 through V4. Sweet. So what causes a bundle branch block? So this is a left bundle because the machine says it. That was a joke. Don't trust the machine. It's a left bundle because we're pointing down and the QRS is wide. So left bundle. What causes a left bundle branch block? Anybody know? Anybody care? At 9:20 in the morning. So anything that jacks up the left side of the heart. So remember, the electrical impulses, the way I think of this is almost like wiring in the heart, right? So in a normal heart that's healthy, the wires are still nice and well. If you get left-sided heart swelling, right, growth, strain, okay, it stretches this wiring and it slows the amount of time it takes to get through there. So that's why that QRS gets wider. All right, so anything that jacks up the left side of the heart is going to jack up the EKG, and that's what leads to a left bundle. So chronic high blood pressure makes the heart work harder. So if you're 50 and you've had blood pressure that's 200/100 for the past 20 years, you never got it treated, guess what? You probably got a left bundle, right? You got left-sided heart strain. Okay, if you had a big infarct that damaged some of the blood supply through here, that'll make that heart get bigger as it tries to make it work better and makes the electricity move slowly through there. So anything that jacks up the left side of the heart can cause a left bundle branch block. Okay. Before 2013, if somebody had a left bundle branch block on their EKG and they were having chest pain, we said they were having a STEMI. We really couldn't figure it out. We got some ways we can kind of interpret that now and look at it a little bit different. But a left bundle was a Y complex QRS and basically a downward deflection in V1. There's some other criteria out there. If you'd like to use that, that's fine. There are a lot of ways to define it. But again, there are a lot of days that I'm just way too tired and I got to have one pathway to figure out is a left bundle versus a right bundle. So left bundle, QRS complex is wide, greater than 120. I go to V1. If V1's pointing down, I'm going to call it a left bundle. All right, I can go back and confirm there's no Q here, but still, left bundle branch block. That's a mesmerizing picture of a heart, isn't it? Yeah. There is something called Scarbosa's criteria. All right. So basically, that's a strange picture. Concordant ST elevation. So ST elevation normally, QRS complex goes one direction, T wave goes the same direction. All right, that's a STEMI. All right. The depression, like we saw in V1, does that change at all? Yeah. Like we saw in V1, 2, or 3, ST depression is a STEMI. The only change really is in V1 through V4. Discord is good. So QRS complex one direction, T wave the other direction, you get one big block. All right. So going back to this left bundle, we went through it initially. So I'm going to look at 1, AVL, 5 and 6. There's no ST elevation, but I got depression. It makes me uncomfortable, but it's not a STEMI. 2, 3, and AVF looks okay. V1 through V4, I would argue that's elevation, maybe a little bit there, but those two, right? AVR is opposite of 1, not elevated, so it looks okay. I'm gonna go back, peer interval is good. QRS is wide, so I go to V1. It's pointing down, so it's a left bundle, all right? But now I know if I Scarbosa, I can look at V1 through V4. This is discord, and it's not one big box. So this is a reasonable EKG, not super concerning for a STEMI. And I see everybody's eyes are crossed, and I appreciate that. The only way you get good at EKGs is looking at a lot of them. So if you're working at an agency where you make 20 calls a shift and you're doing a 12 lead on everybody, yeah, you're good. If you're not, you need to look at these when you're on shift. There's some good sources out there. There's Wave Maven is a good online source. Life in the Fast Lane is another online source that's EMS geared. All right. And then the third way would be that you get feedback from the hospital on your patients. When you get to the hospital with your patient with a 12 lead, you show it to the doc, you try to get some verbal feedback. And as we move forward with the way the billing practices are at hospitals, hopefully we'll get some more written feedback as well. All right. Too fast, too slow, or okay? Okay, praise God. Somebody talk. Thank you for speaking. Very good. All right. That was the easy one, right? Yeah. Yeah. Machine said it's 95, but we don't look at the machine. So I'm going to say 300, 150, 100, it's not 100. So I'm content. All right. It's not less than 50. It's not greater than 140. So I look at injury patterns. I'm going to look at leads 1, AVL, 5, and 6. No ST elevation. Looks a little bit funky over here. Looks different. All right. But funky is not STEMI. So we're good. Next place I'm going to look at lead 2, 3, and AVF. I don't see ST elevation, but I do see some depression in 3 and AVF. Concerning, but it's not a STEMI. All right. Next place I go is V1 through V4. And I recognize we got these deep ST depression. So in my mind, I'm thinking, okay, this is a posterior infarct, right? But I'm going to go through every EKG the same so I don't miss stuff. So I'm concerned. This is a STEMI. I go to AVR. AVR is opposite of 1. It's not super elevated, so I'm good. I'm going to go to lead 2. PR interval is reasonable. QRS is wide. So QRS is wide, so I have to go to V1. But now I got a big deflection. My biggest deflection is going up. So it's not going down. So this isn't a left bundle. This is a right bundle branch block. All right. So I recognize it's a right bundle, and the rules for right bundles are different in V1 through V4. All right. So good news. The rules for a right bundle is this is normal. So I feel better about this. Okay. Now, if dude is sitting there, diaphoretic, clutching his chest, he's got 6 stents in his heart, what am I going to do? I still treat him like he's having some kind of big STEMI, right? But with the right bundle, this is reassuring. All right. What causes a right bundle branch block? Y'all can speak redneck. I speak redneck. Messed up right side of the heart. Yeah, something that jacks up the right side of the heart. Yeah, cool. All right, cool. So key thing on this is the approach to the EKG. You always do it the same way. If you don't like my method, I'm not offended. Find a way that you can do it the same way every time so you don't miss things and people die from that. All right. So I do 1 AVL, 5, and 6, 2, 3, and AVF. V1 through V4, I'm uncomfortable. I'm starting to think, okay, is this a posterior infarct? Does it fit the patient situation? I hit AVR, right? And then I go over here and I look at lead 2 and I recognize I got a Y complex QRS. So I go to V1, that's pointing up. So it's a right bundle. So now I feel better about this. So yes, patient's still going to get aspirin if he's got chest pain. I'm still going to do things of that nature, but I'm more reassured it's not a STEMI because it's a right bundle. So right bundle branch, left bundle branch block. When EMS first started out with paramedicine, we pushed really hard. There was a big push for 3-lead rhythm interpretation, right? VTAC, VFib, SVT, heart block, those things. Because when paramedicine was conceived and started, if you had a heart attack, you know what the treatment was? They took your cigarettes away, made you eat bland food. We hung lidocaine, so if you went into VTAC, you didn't die. Really didn't help much, okay? And we hoped you got better. We can actually do things to fix you now. We can do cart casts, we can do lytics, the medicines that we can do to help kind of rejuvenate. That's not a good word, but the heart. So it's really important now that as medics, you guys are the gurus, the 12 leads, just like you were the gurus and are the gurus of the 3-lead. All right. You guys should be recognizing STEMIs, not STEMIs, left bundles, right bundles, even before they get to the hospital for the docs. All right. It's a great screening tool. So causes the right bundle, anything that jacks up the right side of the heart. Okay. What are some things that can cause up the right side of the heart to get jacked up? Yeah, the left side's jacked up, right? So just concentric, right? What else? People that smoke, right? They get pulmonary hypertension, right? So the right side of the heart pushes the blood to the lungs. So if you got pulmonary hypertension, this side of the heart has to work harder. So it gets bigger because it's got to work harder. So folks who have COPD, folks who smoke, folks with pulmonary hypertension, what acute problem could make you have a new right bundle? Dyspnea, hypoxia, chest pain that we talk about a lot now. It's one of the diagnoses of the decade. So you got a guy with a swollen right leg. Now it's, yeah, PEs. Yeah, acute PEs, right? Acute PE will make you have acute right-sided heart failure. You may see new AFib because this is stretched out. You'll see right bundle branch block, but you put it in the setting of what the patient looks like. Gives you a lot of information. Cool. So that's a right bundle. So if you're comfortable with this, fine, keep doing what you're doing. If you're not comfortable with this stuff, I would recommend you find a way to kind of go through, look at a lot of these EKGs, so that when the time comes and you're exposed to the patient with these problems, you know what's going on, all right? This is just a little diagram kind of showing, excuse me, where the injury patterns are. So inferior right-sided is 2-3 in AVF. The coronary artery comes off the aorta. That's why the AVR elevation is concerning if it's elevated, because the right and the left side come off of it. The lateral is 1 AVL and 5 and 6. And the main portion of the heart is V1 through V4. Some of my slides are transitioning, but I show this every time. What's wrong with this picture right here, guys? The blood pressure, right? You can't have that, right? My point to that is don't trust the machines. And then the next slide would have been, we should have learned in 1987 not to trust the machines. And then for you cool guys, we should have learned in 1981, but the slides aren't transitioning well. So 87 was better than 81. Inappropriate humor. Yes, yes. There's somebody on every shift like that, true? Yeah, except for the cigarette. Yeah. All right, let's look at this one. Too fast, too slow, or okay? The rate. I said the rate's okay. Yeah, yeah. And sometimes you don't have to calculate. You can just kind of look at it after a while, right? But to calculate it, 300, 150, 175. So yeah, between 75 and 100. Doesn't really matter. Is it 72? Is it 86? Don't care. The next thing I'm gonna look is injury patterns. 1, AVL, 5 and 6, 2, 3 in AVF, V1 through V4, AVR, right? Then I'm gonna go back and look at my intervals, go over here if I need to, right? Then before I put it back down and call it a day, I'm gonna look one more time because some days I'm way too tired or I'm talking, doing something at the same time as I'm looking at the EKG. So what do you think about this one? And our definition should be for the 12 leads, for the most part, is STEMI or no STEMI. The cardiology group where I work, they used to laugh at us because they review our EKGs. We get reviewed just like you get reviewed, right? Everybody gets reviewed. And then always laugh. The ER docs only can say STEMI or no STEMI. And I'm like, yep, that's my job. It's a STEMI or it's not, right? Do I want to wake you up at 2 in the morning or not wake you up? And the answer is I don't want to wake you up, but sometimes I got to. So STEMI or no STEMI on this one? Okay, where's your STEMI? Yeah, perfect. Yeah, at first glance, I look at this and you see so many people with left to right bundles, and this is normal that you kind of think of that way, right? But if you go back and you're looking at your intervals here, if your interval's good, that QRS complex is fairly narrow. I wouldn't be hard pressed to say that's wide. So there's no left bundle. So this is a STEMI, guys. That's a elevated there. That's elevated. That's a STEMI. And this is one that would be easy to miss at 2 in the morning when you're tired if you don't have a pathway to go through it. At first glance, to me, I'm thinking, okay, it's a left bundle. I'm not super concerned. Anybody know what that is? Yeah, that's trichomonas, so it's tricky. My slides aren't transitioning. I thought it was funny. It's all about me. So good call. Yeah, that is a STEMI, right? And I bet you my $7 in my wallet that the machine's not going to say it up there either. Okay. Are the ERs around here, are they not busy? Do you go straight back? Anybody know? Or nobody's going to answer? Yeah. Every ER is busy. I don't care where you are. Even the ivory towers at academic centers, they're more like styrofoam towers, but they're busy as well, right? So if you miss this and you're on the wall for 30 minutes, big risk for this guy having a change in status. All right. Things that kill you in a STEMI in the first couple hours is VTAC or VFib. All right. The other problem is that as this goes on being untreated, the heart gets more and more damage. All right. If we treat this pretty quickly, this guy can go back to normal life, can go back and be a firefighter or a plumber, do whatever he wants to do with minimal limitations. But if we sit on the wall for an hour and a half, don't get another EKG, and we miss this, the guy's going to have a bad outcome. Cool. So this is not a left bundle. The QRS is not wide. Kind of tricked here if you looked, but it doesn't matter. QRS is not wide, not a left bundle. All right, what about this one? Too fast, too slow, or okay? That's the easy question. Yeah, I'm gonna say it's okay. It looks relative okay. So 300, 150, 100, 75, 60. Yeah, so more than 50. All right. All right, so I'm gonna start looking injury patterns. 1, AVL, 5 and 6. 2, 3 in AVF. V1 through V4. All right. I go back, I look at AVR. Yeah, AVR, yeah, AVR, all right? And then I'm gonna look at my intervals here. QRS, look there if you want to. And then one more time, injury patterns, 2, 3 in AVF, V1 through V4. I'm gonna look at it twice before I lay it down. And before you answer this question, if this is a STEMI or not, make sure you read this because that's pretty important, remember? So STEMI or no STEMI? So you should set up close. You can see better. I see you squinting. Yeah. STEMI or no STEMI? Yeah, STEMI, yeah. Well, 2 reasons. One, probably won't show you something that's not a STEMI, right? What's the point? But yeah, this is crazy. Yeah. You got V1, V2, excuse me, V2, V3, all right? This is a right bundle, right? So QRS is a little bit wide, 132, so that's a right bundle pointing up. So what should be going on here? Those should be down, right? So this is up. Machine's going to stop interpretation for the most part when it says right bundle anyway. So this is a big freaking STEMI on somebody with a right bundle. So maybe it's somebody that's been smoking for 40 years, they got an underlying right bundle, now they're actually going to have a STEMI with this, but the machine did not pick it up. And if you guys don't pick it up, and we as the docs in the ER can't get to you for 45 minutes or so once you get there, patient has a bad outcome. And I got dozens, probably more than dozens, probably got hundreds of EKGs that don't say STEMI that are STEMIs. In the BRIMS region right now, we're pulling this information. So anybody that gets put in our STEMI system and the EKG doesn't say it, we're looking at those EKGs, tying them back up to cath abs, and we're seeing a pretty impressive number of EKGs that medics are picking up that don't say STEMI. All right, let's do another case. This is a 46-year-old female, dull chest pain, chronic in nature. Now she's dizzy. What are you going to do? Initial vital signs from the engine guys first showed up. Heart rate in the 40s, blood pressure is 100 by palpation, breathing about 24 times a minute, statin 96%, and glucose is 120. So what we can do for her real quick. Yeah, so we got to get an EKG, but she's also pretty bradycardic, right? So I'm throwing some pre-oxygenation on her, not supplemental because she's not hypoxic, but this is pre-oxygenation before she codes, right? So I'm gonna throw a couple of liters of nasal cannula on her. I'm gonna sit her upright. Somebody's starting a line. We're starting some fluids, all right? And somebody's doing a 12 on her pretty quick. Oh, Jesus. I like that. Too fast, too slow, or okay. And if you say okay, we got to step outside and talk for a few minutes. Yeah, this is an easy one, right? All right, so I'm going to take a quick second and do my injuries. 1, AVL, 5 and 6, and I'm done, right? I'm elevated there, I'm elevated there, I'm elevated there. All right, I can run back through 2-3 and AVF. I can run through V1 through V4. I can look at AVR. I can go back and look at my intervals. All right, but it doesn't matter. All right, what I have not done is I have not looked at this. All right, so this is a big freaking STEMI. Remember, we talked earlier about bradycardia. It's also way too slow. And what are the 3 causes of bradycardia? Drugs, electrolytes, or ischemia. Which one is this? Ischemia. Duh, right? This patient is super sick. People want to sit here and look at this EKG and try to figure out, oh, they're in heart block, because this looks kind of weird, right? Or is this an escape beat? Who cares? It's a STEMI. Their heart rate is 40, okay? They got a blood pressure of 100. How many adults in Alabama have a blood pressure of 100 normally? None. We're all fat, diabetics, overweight on blood pressure medicine. Who here is not on blood pressure medicine? No, don't raise your hand. Sorry. Oh, great. Got firemen. I forgot you're healthy. So yeah, so sick patient, right? Super sick. So we've already set them up. We did some pre-oxygenation. I'm starting a second line. I'm always getting that AccuCheck. All right, 12 leads done. They can get defib pads, because remember, the things that kill people in STEMIs in the first couple of hours is VTAC, VFib, or complete heart block. And I'm super concerned about this, right? So I'm gonna start fluids on them. People argue, well, what if they have heart failure? I'm like, well, we'll figure that out in a few minutes. It's a second leader, right? The bradycardic, the hypotensive fluids, it's cheap, it's easy. There are a lot of blogs out there that talk about we don't need to do this. Yeah, if you're sitting in a cath lab right now, they probably don't need fluids. They need to be cath. Or they're not. They're sitting in their couch and you're in their house. They need fluids to increase that blood pressure. All right. They also have a heart rate of 40. Remember, the heart gets its blood supply every time it beats as well. Heart squeezes, blood goes out the aorta, and it falls back down. 40 beats a minute in a STEMI is not enough. You got to improve that coronary perfusion pressure. So increase the heart rate. Atropine's quick, it's easy, it's cheap, there's no risk. 1 milligram of atropine, if it works, great. High five your partner, take a puff off your cigarette, head to the hospital. If it doesn't work, you got problems. You got other things you can do, right? What are some other drugs you can do for this bradycardia? Y'all carry push dose epi? Yeah, you got push dose epi. You can start an epi infusion. Y'all still carry dopamine here? Dopamine is reasonable. We don't use a lot of dopamine in the hospital for just hypotension or sepsis, but with somebody with a slow heart rate and hypotensive, dopamine is going to increase the blood pressure. All right. Normally, you want to stay on scene and manage these pretty quickly. On scene, stabilize them before you start moving. The problem with the STEMI is there are things that we can do at the hospital that you can't do, right? So we can give them a thrombolytic, we can take them to the cath lab. So this patient is one you're going to start your treatments and start moving to the hospital, almost like a trauma. All right, so dopamine. The way I recommend doing this is a titratable drug. So I spike the bag, prime the line, hook it to the patient, and I open it up. All right, I reach over, I cycle my blood pressure, I'm starting my second line, we're getting ready to get the mansack or stretcher, whatever you can do to get them out to the rescue. All right, give them a minute or two, then I'm gonna look over at the monitor. If the heart rate is now 70, blood pressure is better, I'm gonna slow it down to 10 mics per kilo per minute. Then have somebody break out the cheat sheet, calculate the drops. All right, if I look over the monitor and the heart rate is still 40, they still look like dirt, I'm gonna roll it down to 10 mics per kilo per minute, have somebody figure out what that rate is. And I'm gonna start thinking about my next drug, which would be a push dose epi or epi infusion, or you can go ahead and pace somebody in the state of Alabama. All right. I would advise if you're gonna pace somebody, they should be altered and symptomatic, not just symptomatic. Because if you start pacing them, they're gonna cuss you at 60 beats a minute. Push dose epi, if you're using that, wherever you're using that, just make sure you train. What you don't want to do is give 1 to 10,000 epi. As a push dose. You want to make sure it's 1 to 100. If you start pushing the 1 to 10,000 without diluting it, and you give somebody half an amp of this, what's going to happen to them? Yeah, they go from bradycardic STEMI to VTAC. Now, it's the easier algorithm, right? It's basically you shock and do CPR, but it's poor form, especially if it's a neighbor and you know them. And then obviously we can always pace, and we'll play with some pacing scenarios here in a little while. So supportive care for bradycardia is the ABCs. I think atropine. If I'm concerned about hyperkalemia, I do calcium. 98% of my patients that are bradycardic get calcium from me, because when I give epi or dopamine, what that does is increases intracellular calcium at the heart level, so there's no risk. And I also don't know if they're hyperkalemic or not. That EKG we just saw, we know that's not hyperkalemia, right? We know it was a STEMI, so maybe not calcium then. If I'm gonna pay somebody, I'm gonna intubate them. All right. People talk about blocks, and I say, who cares? It doesn't matter. Some of these folks who have high-grade heart blocks will alternate from a heart block to not a heart block back and forth. So I treat the patient. All right. If I end up pacing somebody, they're going to get an implantable pacemaker no matter what. But back to this EKG, we got to do more than just the bradycardia on this patient, right? Because it's a STEMI. So I'm managing the patient acutely with atropine, the fluids, thinking about dopamine. I'm moving toward the hospital, all right? Because we can do some things to fix this in the hospital. But I also got to do some things in the field to manage this patient. So what other drugs do they need to manage their STEMI? So let's say we gave them atropine, heart rate is now 70, blood pressure is 140, still having a big freaking STEMI though. What drugs do we want to give them? Okay, so why would you give them nitro? Yeah. I would be hard pressed to give the nitro. That's pretty, I mean, you can technically, but if I just had somebody with a heart rate in the 50s that I had to give atropine to, and I give them nitro, my concern is going to drop the pressure again. So if I pop nitro on somebody, if I give atropine to somebody, I probably would not give the nitro. Okay, what's the more important drug for this dude or person? Aspirin. Yeah, they need aspirin, right? So there are a lot of mnemonics. There's the Mona, there's the Fona out there. So there's morphine, oxygen, nitro, aspirin. You work it backwards. So aspirin's super important. Aspirin works on platelets. It takes this, the clot that's causing the STEMI. Aspirin's not going to make the clot better, but it makes the clot not get bigger. So if there's any blood supply distally, you start popping an aspirin on them, it's going to make that part stay open, hopefully, right? Because this completely occludes your hose. They go into VTAC, VFib. So aspirin is very important. Which patients would you not give aspirin to having a STEMI? Sir? Yeah, so if they're reasonable and so they took an aspirin already, you don't have to. I don't have any reasonable patients. I don't trust them. I've had people say they took an aspirin. I look at the bottle and it was like a Norco. Like, that's really not aspirin, right? So if they're having a STEMI, I'm gonna give them a complete aspirin myself. That way I know they got it. If I give them 2, yeah, it's okay. If they get none, it's really bad. So if they say, last time I took an aspirin, I swelled up and you had to cut my throat to put a tube in me, I'm probably not gonna give them aspirin, all right? I still may, but I'm probably not. So aspirin's good. We talked about the nitro. It's in the protocols. It's reasonable. If blood pressure is high, heart rate is up, yes, definitely post that atropine, I mean. Otherwise, nitro is great. We talked about oxygen. American Heart doesn't like oxygen, and there's a hypoxic. So I changed my terminology to not supplemental O2, but pre-oxygenation. And then the EM morphine. What does morphine do for the heart? Anybody know? Anybody care? It makes you go from having chest pain to I'm having chest pain. I don't really care, right? It's like drinking a beer. It relaxes, right? It's a dirty narcotic. It releases histamine. This vessel may get bigger. That's the benefit. Fentanyl doesn't do that. You can do that. If you want to give them some fentanyl, that's reasonable as well. Some people are talking about using ketamine. I would not do ketamine. Ketamine increases blood pressure, increases heart rate. It's going to put more strain on the heart. I'm not a big ketamine fan in STEMIs. We'll talk about plate. This semi-inappropriate humor. Anybody watch the news late at night? There's all kind of commercials for medications that I would never take. Nope. In the hospital, in addition to aspirin, we want to give them what we call dual platelet inhibition. So you've given the aspirin already. That works on one of these receptors. So we'll give them Plavix or Brilinta. There's some IV forms of drugs we can give as well. But the goal is to make their blood super thin so we can improve blood supply distal that clot. That's the purpose of all these medicines. Prevent it from getting worse. All right. This is the mnemonic I started using. I like it better than Mona and Fona. It's SITAIVNRTLPOM. It's easy to remember. I got a tattoo, but I can't show it to you where it is. But it's suspect, identify, and treat. and then transport 2 Ts, right? So I suspect someone's having acute coronary syndrome, they're having chest pain, they're nauseous. All right, the diaphoretic, I get the 12 lead, I identify it, and then I treat them, okay? And the humor here is aspirin, IV, nitro, if indicated, and then we put the defib pads on, ride the lightning pads, and then we do oxygen, and at the end, I give a little bit of morphine for them if they want it. But you're happy to write that down if y'all need to. SIT. I know. Thank you for laughing. I think it's really funny. Some folks love mnemonics. I'm not a big mnemonic guy. I like ABCs. That's my mnemonic. I know everybody does this on every STEMI patient. It's the state required thrombolytic checklist. You do this on your strokes and your STEMIs, and you hand these to the hospitals. I know you do. We all have to do it, right? Me too. At least ask the questions, have the information. It's pretty important. So if you got this guy having a STEMI and you started this workup, and as you pull into the hospital, he goes into cardiac arrest, all right? Technically, we could give him a thrombolytic and open this clot up and help him. If I got proof that he's got a STEMI, you got an EKG, and you can tell me that you've screened him and he's okay to give him these lytics. So if he's got a history of a brain aneurysm, if he's had a recent stroke, if he's already super anticoagulated for some reason or has hemophilia, I can't give him these lytics because it won't do any good. He'll die from that. So there's no reason to waste that money or time or energy. Maybe I should waste my time trying to get triology on the phone, get him the cath lab instead. So know the questions to rule people out for thrombolytic use. Okay. When you get done with your call, give this information to the hospital, okay, to document it. But in practice, when you get to the hospital with this patient, find the doc, tap them, hey, this is my STEMI, this is my EKG, this is what I did, and I've ruled him out for contraindications to lytics. Write on your glove, write on a napkin, write on the back of your IV fluids, whatever you got, and then transition this when you go back and do your documentation. Remember, a thrombolytic is different than a blood thinner. Blood thinners make the clot not get bigger. If I give you a thrombolytic, every clot in your body breaks apart and flows downstream. So if you had a recent stroke, all right, and there's a clot there, or you had a recent hemorrhage where you had a busted vessel, that's completing your brain. If you had a recent GI surgery, okay, there's a big risk to these drugs. But if you're having a STEMI and you can take it, and that's the only choice we got, it is what it is. We won't talk deep about oxygen. The literature talks that it's bad long-term for strokes and STEMIs. It is, but long-term is greater than 24 hours, and you should not have your patient in your truck for 24 hours. If you do, please call me. There's something wrong. The reason you put defib pads on your patients having a STEMI, I would argue this is a STEMI, 2, 3, and AVF is up. V2 through V6 is up. There's not many leads that don't have elevation. You can see goes right into VTAC. They actually had the pads on the patient. They shocked him. He was screaming, calling their mama names when he came into the ER, but he was alive. He gets sedation, he gets anticoagulation, he goes to the cath lab, and he gets to go back out in life and be mean to people again. So SIT, AIV, NRTL, POM. Remember that. So the first guy that we saw, this is his feedback from the hospital. The hospital uses in the BREMS region, their first patient contact to EKG time. So they go through the charts, the EMS charts, and find that. And do we recognize STEMI or no STEMI? And that goes into the time frame. We used to have door to balloon less than 90 minutes from the hospital entry to cath lab. Those times have been pushed back in our region to from time we make contact with the patient from EMS till they go to the cath lab. So this guy, this EKG was real EKG from North Birmingham. We got him from the street. First EKG was great. Well, not great, but it was great that we got it. It was horrible EKG. Door to cath lab, 89 minutes. So we met our metrics that we set for ourselves in the hospital in the pre-hospital area. This is his cath report. So you can see he's got a clot through there. They put a stent in it and perfusion is much better. So this is where we need to be at statewide level. We need to be able to look at these EKGs, get feedback to the crews, give you the cath report, let you know, was it a STEMI, was it not a STEMI, what do we do? Was your treatment good? Was it bad? Should you have given that nitro? Was the nitro okay? Did it make a difference? And that's how you learn, right? Pretty cool stuff. I think I got like 1 minute. Nobody get through all this. The purpose of this slide, I was doing a talk on liver issues recently, and I'm going to pull up the cause of death in the U.S., and this is 2021. All right, so liver disease and cirrhosis is the 9th leading cause of death. I'm like, that's pretty high, right? It's usually up in the top 15, all right? And I started looking at this: heart disease, cancer, COVID, stroke. Has anybody ever seen anybody die from an opioid overdose? Nobody's ever seen that? And I see it every day, right? Every day. So that's not even up there. So I started thinking, what in the world is this coming from? And the point of this is that when you look at research or data, if there's garbage going in to the numbers, there's garbage coming out. And so I say that for those of you online and here, the CARES data that we get for cardiac arrest. If you're a transporting agency in this state, you have access to put that data in. Please put that data in and put it in legitly, so we know if we're doing the right thing. So we know if that first dose of epi at 3 minutes is good, and should we repeat it at 5 minutes, or should we not give it again? If we don't get this data, we're not going to get better. For the hospitals online listening in, we got to have that data put in by y'all as well. So we got to be able to look at the stuff and say, are we making a difference or not, or we won't get better. So that was the point of this slide. I got several more. I guess everybody dies. But I don't think we have time to talk about the liver cases today. So let's take a 5-minute break. We'll come back. Chief, comments, questions, concerns, anybody?
Yeah, we did have one question come in. So if we recognize the left bundle branch block, we go through scarbosis criteria to determine STEMI, no STEMI.
Correct.
What do we do different, if anything, if we recognize a right bundle branch block?
Yeah, the only difference with the right bundle is you can say when you have those posterior changes, that ST depression T-wave inversion in V1 through V4, if you see it, you can be more comfortable it's not a STEMI. That's the only benefit.
If there's ST elevation with the right bundle block, it's
it's a STEMI.
It's a STEMI.
It's a STEMI. Yeah. Yep. Cool.
Thanks. Hey, thanks everybody. We're going to be gone for about 5 or 10 minutes here, and we'll be back with Dr. Davidson. So please stay tuned.
All right, I'm Blake Davidson. I'm one of the EMS fellows with Ferg. I'm originally from Arkansas. Did my training in Kentucky, so don't hold that against me. I'm just making my tour around the South. Today we're going to be talking about some neurological emergencies. So neurologic emergencies outside the realm of stroke. I say that with a little hesitancy because we may have a little bit of overlap, but I'll do a stroke lecture probably not next month, but within the next few weeks or next few months. I don't have any disclosures because nobody wants to pay me any money. So our goals here are to recognize some of the emergent calls or some of the emergent needs of altered mental status, right? It's one of the most painstaking and annoying things that we get called for, people coming to the hospital, is altered mental status, because the differential diagnosis is extremely broad. Same thing with things like dizziness, right? Things that we can't really assess or can't have patients tell us what's going on. It's a lot more difficult to manage than a broken arm, right? We're going to talk about some like neurologic trauma as well, and trying to recognize injury patterns in trauma patients and how to manage those in a out of hospital setting. And then weakness as well, right? Trying to figure out when is somebody actually weak and when do I really need to be worried about it. Okay. I am a big case-based person, so most of these are going to be going off cases, and we'll talk about kind of what's going on after that set. So the first one, dizziness, our favorite call and favorite inpatient workup. So you're dispatched out, you got a 56-year-old female, past medical history of hypertension, hyperlipidemia, diabetes, coronary artery disease, just your standard. She's been dizzy. States that she was just sitting on the couch, she was watching TV, started to feel dizzy, and feels as though she can't sit up straight because it's so intense. She has a little bit of nausea and headache. You get there, she's on your physical exam. You notice that her eyes are rocking in a vertical pattern. And what is that rocking that I'm describing? Called nystagmus. So it's a vertical nystagmus. She can't walk across the room without falling. whenever you ask her to sit up, so she sits on the couch, you have her cross her arms, and she she's able to do that. Okay. What do you guys think is going on with this lady? Or what else do you want to know? No trauma. No, just the nausea, the headache, and just feels like she can't. The dizziness won't go away. This uneasy feeling. The seizure, yeah. She doesn't have any history. You get some vitals on her, so vitals are vital, right? So always check these. And normally, whenever you're given in like any type of exam or any type of question, you're normally one vital is normally left out, and it's normally the most important one, right? So what's left out here? Right, blood sugar. I know it says glucose down there. My notes are hidden up here. Is that my mic that's giving that feedback a little bit? Well, I think it's just because it's where it's at on my jacket. Maybe I'll try to adjust it. So vitals are fairly normal. Glucose would be 98 in her. You try and move her to the stretcher, and she really can't do anything. And you do a finger to nose test, she has an overshoot. What's the thing that I'm like most concerned about this lady? Stroke, right? Specifically, I said we're not going to do a stroke, and I'll lead off with a case of stroke. But this is a very specific type one that is extremely rare. It's a posterior stroke, a cerebellar stroke, right? There are some things that are very particular during an exam on dizziness that we have to do. One of those, whenever we have them sit up straight and cross their arms, it's called the Romberg test, right? If they're able to do that, if they're able to sit still and close their eyes and not sway, that means that their inner ears are working okay. It's the brain that's the problem. Whenever they have their eyes open, it's a feedback problem. So if that test is negative, it's more likely to be a central cause, a brain cause, right? And so we want to be a little bit more worried about them. If you have them try and stand up and close their eyes and they fall forward, that's actually a good sign. That means that something's probably going on within the inner ear and not within the brain. Okay. Again, it's a very uncommon cause of dizziness. Dizziness is something that you have to get a really good history of trying to figure out what exactly do people mean by dizzy. Do they just feel nauseous? Do they feel like their room is spinning? Do they feel uneasy? Do they feel like they can't have a good sense of their self, right? So history is extremely important in these, and then trying to figure out a good neuro exam, right? Everybody should have a very quick neurologic exam that they're due that can get all of your system, right? The finger to nose to get ataxia, do a Romberg, it's super quick. Test all your cranial nerves and a quick strength test. We talked about the Romberg test. Another thing that is really concerning is if people can't walk straight, right? If you try and get them up and walk across the room and they're falling over the side, it's something that I'm going to be a little bit more concerned about. The management of a cerebellar stroke is going to be similar to other strokes that you have, but the important part is where to take this person, right? If you're concerned about a cerebellar stroke or they've got something on physical exam, you want to try and get them to a stroke center if you can. Okay. This is the reason why we hate dizziness, right? Is because this is when I'm writing my note in the hospital, all of these are going to be included somewhere in it, right? And I've got to rule out a lot of these problems, whether it's medications, whether it's an inner ear issue, whether it's infection, a dissection in the carotid artery. There are so many different things that can cause dizziness that is annoying, and most of it is normal, just regular stuff, right? So physical exam is important. Case 2, seizure, another pretty common call. Right, you got a 45-year-old male. He's got a history of seizures. He's got diabetes, hypertension. You're called out for a seizure. You get there. He's having tonic-clonic movements, bilateral, upper and lower extremities, jerking all around. It's been going on for about 10 minutes. So what's the first thing we need to do for this guy? Airway. I like that a lot. So ABCs, right? For these guys, make sure he's not foaming out the mouth. He's not choking on his secretions. He's not vomiting. If he has, turn him on his side. Make sure that his airway is intact. You can start him on some passive O2 as well, right? So ABCs are intact. What should be our next thought? Specifically in this guy. So benzos, okay. So, and then what other thing do I want to check in my initial evaluation of this guy? Right, sugar. So you'll find out in any neuro talk that you get, blood sugar is going to be one of the top things that people care about, right? So that's one of our corrections, especially if this guy, I know he's got a history of seizure disorder. He's also got diabetes. You know, what if he took too much of his insulin and now his blood sugar's 32, right? So that's something that benzos, no matter how many benzos you get, if you forget that blood sugar, it's not going to work. Okay. So you check him, his blood pressure is elevated, heart rate's elevated, can't get a respiratory rate on him because he's seizing. He is satting okay, so you're all right there. He's got no obvious wounds. He's got a little bit of blood coming from his mouth, 3 millimeters. So we said benzos. What benzos are we given? First said how much? What's that? To how? IV. If you were to give it IM, how much are you going to give? What's that? Say 4. Yeah. So you can much have a higher dose. You can give 5 to 10 if you have it. When it comes to seizures, if these are real deal seizures, you can't. It's going to be hard to give too much benzos. You can give a higher dose, right? And especially if you have, like if we have Ativan, the IV dose is 2 milligrams per kilogram. I'm probably going to give 4 on my initial dose. I know protocols are different, but you can give that initial dose. And if that doesn't work, pretty quickly you can give that second dose. The Versed acts faster than the Ativan does, so it should act pretty quickly. If it doesn't work, you can give another dose in a short period of time to try and stop the seizure, right? Our number one goal is to get the seizure controlled, okay? In real deal seizures, a higher initial dose has a good overall outcome and try and get this stopped because we don't want them to go into status, okay? So we talked about treatment for seizures. That's benzos, and then benzos, and then benzos, and then we talk about something else, right? So you in a real deal seizure, you can give a ton of benzodiazepines, and people be okay, right? What's the big problem if I'm giving this person 6 milligrams of Ativan in 5 minutes? And their seizure breaks? What do I have to start worrying about after that effect? Blood pressure. What else? Airway, right? So if you're given a high dose of benzodiazepine and you stop their seizure, all that excitatory stuff's stopped now, and now you've got benzos on board. You have to worry about that respiratory depression. So make sure that if you're giving these high doses, to make sure that we have them on N-tidal or something of that sort, to where you can monitor their airway and make sure that you can control their airway if needed. So these are our doses of benzodiazepines. Notice it does say you got a max of 2 milligrams. It's not the case. You give 2 initially, followed by 2, followed by 2, followed by 2. Once they get to the hospital, does anybody know how long somebody has to be in or has to have a seizure in order to be able to call it status? Some people will stretch it out to about 15 minutes even. Okay, so 15 minutes in the setting of they've also already received benzodiazepines, right? And then we talk about what can we do after benzos. So some people will reach into like barbiturates. Some people will reach into some of our anti-epileptics at what we use in the hospital. I don't like to use too much like data and too many papers whenever I'm doing lectures because it gets too boring. But there's a trial. It's the ESET trial. It was a very large randomized controlled trial talking about how we manage status, really, right? Especially on the in-hospital side, and what anti-epileptics can we use to be able to help people out. The important part from a pre-hospital standpoint and from an early management standpoint is that the doses of Ativan and the doses of benzos that they were using initially were pretty high. The average time or the average dose of benzo before somebody got Keppra or phosphanatoin was around 5 to 6 milligrams beforehand. So the higher dose of benzodiazepines is associated with faster onset of seizure cessation. Again, so just kind of a wrap up of that is that you can use IM medications if you can't get an IV. If they're having a true tonic-clonic seizure and you can't hold them down to be able to get IV access, you can use IM meds as needed. All right, this is a very specific one, and I don't have any prizes, but I'll give good kudos to anyone who can get the answer to this question. This is you got a 5-year-old, you get called out for seizure. Family just immigrated here from India, and the child was in the family bathroom. Started having a seizure. Mom heard a crash. You get there, and the kid's obviously having an active seizure. You give multiple doses of imidazolam, and the seizure's not stopping. Right? You get a blood glucose of 98. What information is crucial to be able to try and treat this kid? Let's see. Right. So medications that the child has available to, right? So whether it be beta blockers, which if this kid's got a super low heart rate, and some of those can also cause hypoglycemia. Whether the mom's history, right, or the family history, like does the mother have diabetes and the kid got into the diabetic medications. So in this one, and some of these, like some where tuberculosis is a little bit more prevalent, and they come over and they're being treated for chronic tuberculosis, take a medication called isoniazid. You can get isoniazid toxicity pretty quickly, or pretty easily in these young kids, and there's a very specific medication to be able to treat this called pyridoxine. It's just a B vitamin. But that is, the benzos are not going to help those types of seizures, right? So when you're talking about like these kids that have had a first-time seizure, the history is extremely important, right? If we don't get those specific ports, the travel history or the medication history of family members, we might not ever know what caused that seizure. You got a 4-year-old child who's weak. They call the EMS. So the child had a cold a couple weeks ago and just had a persistent cough that's just nagging, and they can't really get rid of it. So mom looked online and had some old remedies for honey. Noticed that she had some local honey that she bought at the farmer's market. Started giving it to the kid, and it helped a little bit. The kid quit coughing, but he also quit moving. Right, not really eating very well. Seems a little bit has pretty poor tone. You go in there and the baby's not crying. You're trying to start an IV and he doesn't move. Not really breathing extremely well, and you notice the pupils are dilated. Botulism, right? So floppy baby. This is a floppy baby, right? So it's got a big tone. And so what in the history tells you that this might be botulism? Honey, right? So unpasteurized honey. Any other scenarios in which would kind of lead you to botulism outside of the unpasteurized honey? So there are a few cases that we had during residency. I know of 3 specifically. So if you have a child that's near like an active construction site or near somewhere where they're doing a lot of digging, those botulism spores can live within the dirt, and whenever they're doing all this construction, the spores can be released and affect the kids. There was actually in Eastern Kentucky, when I was training, they had a big flood, right? And whenever they were doing the flood, it disrupted a lot of the area, and one kid ended up getting botulism presumably from all of that destruction. So it's fairly unique. What am I worried about in botulism? Like if I think a kid has botulism, what's the first thing I have to worry about or think about whenever I'm examining this kid? In my management, airway, right? So do y'all know what the treatment is for botulism? Not much, right? There's an antitoxin. You can give the antitoxin for people that require intubation, but for most part, it's just supportive, right? The biggest way that I can support this kid is supporting their airway, right? So you can start them on end-tidal, check their respiratory effort, and intubate them if needed, right? So there's, this is considered part of the differential diagnosis for a floppy baby, or basically just an infant or a child with poor tone. It is a descending paralysis, meaning that the paralysis is going to start from the head and go down to the feet, right? So you'll start to notice, and if it's an adult with botulism, you'll start to notice an eye droop. They'll have some troubles swallowing, troubles with their secretions, and may dry up. And it is strictly a muscular paralysis. Okay, so they'll still have intact pain and sensation, just might not be able to move. So a baby wouldn't flinch whenever you started an IV. It might hurt, but they can't move it. So the diagnosis is largely clinical. We can get like a toxin inside the hospital. We could test their stool is the number one way to be able to get it, but otherwise it's mostly clinical. And then the management is supportive. You intubate them, wait for them to be able to clear it, and then extubate them as needed. Okay, so this is one that this next case is one that I'm sure you guys have your regulars, people that you pick up every single day or every other day, and you get called out. And it's really easy to get super narrow in our approach, right? They have the same complaints over and over again, or some of these people may have the same complaint. They're even seen in the ED for a month with the same complaint, and the ER has that same mindset of this is so-and-so, we're going to give him some Tylenol. He's going to go home after he gets a turkey sandwich on the way out. These people are at high risk for having bad stuff for that exact reason, right? Is that they kind of get pigeonholed, and we have a bias toward them. So we still need to be careful on every patient that we see. So this guy, you got Wallace. He's a 45-year-old guy. He's always in. He uses IV drugs. He always calls in for all kinds of complaints, right? Today, he's saying that he feels hot. He's been having chills whenever he is sleeping out under the bridge. He's got back pain. You are trying to get him up and walk. He's having a difficult time walking. Says that he's not able to walk the street like he normally does and make his normal rounds. He's having to use increasing dose of IV fentanyl that he's getting from the streets to control the back pain that he's having. His vitals are significant for a heart rate of 108, and he's got a temperature of 100.1. Whenever you do your physical exam, you try and get him up on the stretcher, and he actually can't get on there this time because he's having a hard time standing without you holding him up. He can't walk without a cane, which is abnormal to him, and he has midline lower back pain, so pain right in the lower lumbar region. What questions are you going to ask next, or am I going to ask next that would make me really concerned about this back pain? Okay. What's that? Right. So urinary hesitancy. So he tells you that he is having a little bit more difficult time going to the restroom. He feels like he has to, but he's not able to empty he doesn't feel like he's able to empty his bladder completely. Okay. What's that? Okay. So yeah, he's got no history of stones, right? So that's definitely part of our thought process. Does he have an infected renal stone? And then what else? What part of the body am I worried about if somebody that's having new weakness, new lower extremity weakness, he's got back pain, he can't pee. What else can cause some of those symptoms? So talk about our spinal pathology, right? So if he's got something, what's that? Right, like a compressed disc. So we'll call this due to they can form abscesses within your spinal canal. Okay, and that causes what's called an epidural abscess. I think it's just my jacket. So essentially what happens is these people that are using IV drugs fairly frequently, they are more at risk for bacteremia, right? They get the bloodstream infections, and what happens is they get a bloodstream infection, and that starts to seed into their spine. Okay, gets into the spine, forms an abscess, and that abscess grows. And as it grows, it pushes, it puts pressure on the spinal cord. Okay, whenever it puts pressure on the spinal cord, it causes these constellation of symptoms, which what we call cauda equina syndrome. Cauda equina syndrome is compression of the spinal cord in the lower lumbar region, right? It's the most common area for people to get those abscesses. And the constellation, this is the clinical diagnosis of back pain, lower extremity weakness, and urinary incontinence. Okay, so urinary incontinence meaning that it's urinary retention specifically, and it's also associated with saddle anesthesia, which I don't have here. So numbness within the groin region. Okay, urinary incontinence meaning that it's retention, that they're not able to empty. So sometimes you can get like a overfilling of the bladder, and they're like peeing on themselves a little bit because their bladder is so full. So you get those patients, and we think it's just like the normal back pain that they have, that they want to go in and get their either opioid or Tylenol or just somewhere to stay. But he's got abnormal vital signs, and he's got some symptoms that are a little bit more concerning. So even if he's just wanting to, get a Tylenol and be able to go back to the street, I would urge, someone like this to be able to go to the hospital. If they've got epidural abscess with cauda equina syndrome and spinal cord compression, they may need surgical emergent surgical decompression. Okay. All right, so we'll talk about trauma for a little bit. So this one should be fairly common, actually about this time of the year. You got a 15-year-old male who's riding an ATV. He was unhelmeted, hit a tree head on. He initially lost consciousness for a short period of time. Whenever you get there, he's a little confused, but GCS about 14. They're able to talk to you, unsure of exactly what happened, but you're looking around, notice that he probably hit a tree head on, and he's able to talk and do what you need to do. So, how do you want to manage this guy initially? Right, ABCs. Those are ABCs are intact. Again, he's a little confused, but he's got no bloody secretions, bilateral breath sounds, and he appears to be well perfused. His pupils are normal. C-spine. Yep. So you put him in a collar, get him loaded up. The only thing on physical exam you really notice is that he's got a bruise over his left lateral forehead, like right over the temporal region, just above the ear. You got a C-spine immobilized, and you get him loaded in the truck. After about 5 minutes, whenever you're on your way to the hospital, he starts to get a little bit more altered. He gets a little bit more confused. His heart rate goes down, and he loses consciousness and needs to be intubated. What happened to this kid? Right. Yep. And so specifically like an epidural hematoma, right? This is the let me change it to my shirt. So this is the classic presentation and clinical question for an epidural hematoma, right? You've got head trauma that caused somebody to pass out, and then they woke up. They have this lucid interval within a certain period of that the hematoma is expanding, right? And then all of a sudden, as that hematoma expands, it puts pressure on the brain, and they herniate, right? So you have these vital sign changes. It's most commonly caused by a temporal bone fracture, so the lateral side of the head. It causes a disruption within one of the arteries within the brain or within the skull, causing for a bleed. This is what it looks like on CT scan. They have a little bit of a different curvature to them that is a little bit more specific for an epidural hematoma. You can see it up here. So this would be the middle meningeal artery somewhere around here. It gets disrupted and causes this bleeding. This over here is more indicative of like a subdural hematoma. And they look a little bit different on CT scans, and generally are going to be a little bit of a different patient population too, right? So again, we talk about blunt trauma here, mostly over the temporal bone. They'll have loss of consciousness, and then the lucid period. You get the Cushing reflex, which is hypertension, bradycardia, and respiratory irregularity, right? So you have somebody with head trauma. Their vitals are normal initially. We recheck it, and their blood pressure starts going up. Their heart rate starts going down, and then they start having this really kind of rapid irregular breathing. That makes me really concerned that they're starting to herniate. Okay, what things in brain trauma are important for this person? What things can we do even in a pre-hospital setting to be able to help assist him? Right, we can't. I don't think we're doing any field burr holes, Ferg. But what can we do for this kid? What's really bad in head trauma? The worst thing for head trauma? Hypoxia. Hypoxia is bad, right? It's always bad, but it's especially bad in anybody with head trauma. So I want to make sure if I'm suspected of head trauma and this guy's going bad, I'll put this guy on passive O2 and pre-oxygenate him as much as you can, right? Until you get him to the hospital. I'm fine with that. But there are many cases of people with bad head trauma. One episode of hypoxia increases mortality pretty significantly. So it's important that we prevent that. And if this person needs to be intubated, it's very important also that you have your most experienced intubator on available to do the intubation. First pass success with a bougie or video assisted is extremely important. Okay. Not as important in the pre-hospital setting, but fevers are also really bad, and then hypotension. And so if they start to develop hypotension, that is really bad for head trauma. We want to make sure that what happens with hypotension, sometimes if these people have bad head trauma, it decreases the blood flow within the brain, right? So if they have hypotension, they're not able to perfuse their brain as well. So we want to try and increase that blood pressure as much as we can to help the brain get the blood flow that it needs until they can get decompressed. Questions about that at all? Okay. A little bit different of a scenario, but one that is not uncommon for us. You got an old lady now. She's got a history of hypertension, hyperlipidemia, coronary artery disease, she's got AFib, she's on warfarin, she fell. When you get there, she's still on the floor, and she's convulsive. She's got GCS 15. She looks okay. She's got a little bruise on her forehead, but she's fine otherwise. You get to the ED, and you're unloading her from the stretcher, and all of a sudden she loses consciousness and requires intubation. What kind of bleed does she have? So she fell, so subdural, right? So I say she fell, so it's a subdural. Can be a little bit of a mixed picture, right? So some people can have, the biggest trying to figure out is what caused the fall, right? So sometimes subarachnoids can cause falls. I would expect her initial exam to be a little bit different and her to have different complaints if she had a subarachnoid versus subdural, right? But what is also important about her that you got the history whenever you were there is that she was on warfarin. Right, so she fell. She got this little subdural. She's on warfarin, and it slowly expanded. So being able to get a medication history again is extremely important. If this lady lives at home, she doesn't have family around, and we didn't know any of that, and she's new to the system or has never been to my hospital before, got no idea she's on warfarin until her INR comes back and it's 3.4 or 4.5 and needs because she's been taking too much of it. And if you guys are able to tell me that, if you guys are able to get that history, then I can start treatment earlier for this woman and trying to help her out and stop that bleed sooner. So that history is important. Again, so whenever we're getting CT scans, this is the difference in subdural hematoma and an epidural. You see how that kind of looks? It's got a concave picture. It does not cross what are suture lines. You got a subdural hematoma that just kind of normally runs along the periphery of the skull. A little bit of a different one. So it's caused by a venous bleed as opposed to epidural, which is caused by an arterial bleed. As we get older, we get a little bit more room in this space because our brains shrink a little bit, and your brain's got a little bit more room to be able to wiggle around. So you fall, you rip one of those veins, and cause a bleed. It's a shearing injury again, a little bit more of a low mechanism trauma than an epidural hematoma. And then if we have anticoagulation that we can reverse, whether it be rivaroxaban or Plavix or warfarin, really anything that we need to be able to get that done. Another one that's common around this type of the year, this is actually a case that I had in residency. He was 34 years old. He was hunting a tree stand. He slipped out and fell. Whenever he fell, he couldn't move at all. And he laid on the ground for about 30 or 40 minutes. And then he finally started to be able to move his legs a little bit and some bits of his arm. He kind of wiggled over to his phone that had fallen out of his pocket. He called dispatch, and they brought him in. His airway's intact. He is able to, his breathing is equal. He seems to be well perfused. Your physical exam on him is that by the time you get to him, he is able to move his lower extremities pretty well, but he's having a really hard time with grip strength. He's having a hard time with moving his upper extremities too much. But what are we concerned about with this guy? Spinal injury, right? So moving this guy is going to be pretty crucial and making sure that we're not jostling him around. I still don't think a backboard is 100% necessary if we don't have to. It actually shows an increase of problems with these patients. So the one of the big movements is for restriction and not immobilization. Right? So you don't have to strap them down all the time, but we're also not throwing them around. So there's our full physical exam, is that he's got a little abrasion over his head, and otherwise he's got decreased sensation of bilateral upper extremities and full strength in his lower. So I'm worried about spinal trauma in this guy. And the important part for here is the difference between his upper and lower extremities, right? So for it tells me what kind of injury this guy may end up having. Okay. The important part here is also that he is able to move all four, and that he does have some sensation as well. This specific injury is called central cord syndrome. So it's caused by a hyperflexion injury. He falls down, his head flexes extremely forward, and what it does, it kind of causes a pinching of or a shock to that spinal canal. It's characterized by specifically upper extremity weakness that's greater than lower extremity weakness after a short period of time. Their pain and temperature sensation are intact in all four extremities, so that's something that is important as well. This has a pretty good prognosis, right? So most of these, they're not always associated with a fracture or with a bad vertebral injury. It's just kind of more of like a spinal shock. And the important part for these people is blood pressure management. So if you're expecting a spinal cord injury, trending their blood pressure is important for me, right? I want to make sure that I want them on the higher end of blood pressure range to be able to perfuse their back. Okay. This next one, so this is going to be a little bit different in their physical exam. Similar story. 58-year-old guy fell off the house, and now he can't move anything. And you get there, and he still can't move nothing at all. He doesn't really have any neck pain, but he's not moving any of his extremities. You do note that whenever he gets on the truck, he can feel the vibrations, but that's about it. This is anterior cord syndrome, so it's also caused by hyperflexion injury. This is a lot worse of a prognosis, and it's diffuse weakness and loss of, or he's got vibration sensation, right? So unless you carry a tuning fork on you at all times, you may not be able to get that portion, and I wouldn't expect you to. But this is a bad case, right? So it's not necessarily, again, caused by a vertebral injury, but it's a hyperflexion. It's diffuse weakness in all four extremities and caused by trauma. These will need, there's really not much we can do. It's all kind of supportive management and just hope that they get better. Okay, so this one, you've got you're called out to a party. Things got a little rowdy and a guy got stabbed in the back. Now you get there. Oh, well, I'll go back to it in a minute. But you get there and the guy's lying on the ground. He's got a significant amount of pain and he's still got a knife in his back. So we do our ABCs. Everything's fine. We get our initial set of vitals and everything's good there. How do we want to manage this person? How do we want to transport them? Right. So you don't want to go in there and you don't rip the knife out. It's hurting them, so you don't want to take it out. Okay. So that's the important portion here, right? So if you've got somebody that's got a penetrating wound and whatever's penetrating them is still in there, you leave it there, right? And then why do we do that? Like, what's the cause of that? Or like, why won't we want to take it out? Right. So if it's cut open an artery and it's between those two, if it's between the artery and it's causing it to hold there, if we take that out, it's going to bleed a lot more. It's going to be a big problem. Or if it's within an organ, something of that sort, we don't want to cause more damage. So again, secure it as best we can. Now, if it's sticking out 5 feet, we may have to do some maneuver. We may have to cut it down the best we can, or be able to actually get them on transport. The other thing for him is it's in his back, so being able to get him on the stretcher and actually move him will be difficult too. So if you need to have him lay on his side or on his stomach, if he's able to. The other thing about knife injuries is trying to get a description of the blade, trying to see how far it goes. Super fat person that's got like a 1-inch blade on it might not be as concerned. Skinny person with a 3-inch blade that could penetrate into the abdominal cavity even from the back, right, and get your aorta that's running along there. So this guy though, he's still down on the ground. He can't move his right side at all. His right leg is completely gone and movement, and he also has this weird sensation that he can't really feel much on his left side. He can move his left side, but he can't really feel anything on it, which is a pretty specific injury pattern. Where would you expect this guy to be stabbed? Like in the spine, and specifically on half the spine. Okay, there's a syndrome called Brown-Séquard syndrome, and basically what happens is you get a complete transection of half of the spinal canal. And what happens in some of these, and some of the nerves that control pain and temperature, they cross over from your in your spinal tract of which side. They come up from the leg and they enter the spinal canal, and then they go to the other side. And that's why most people say, or that the common thought is that if it happens on the right side of the body, it's the left side of the brain that is affected, and that's because these things are constantly kind of crossing back and forth, right? So what will happen is you transect that and you get these different symptoms, right? So the crossing, some of these nerves cross over twice, and so that's why they might all end up on the right side of the brain, but they cross once they enter the spinal canal, or they cross at different levels. So in this guy, if he's got like a transection at T4, he's actually going to end up getting some on the left side. He's actually going to end up getting some symptoms on the right side above the level of the injury. Okay, and that's all again because of where these nerves cross within the spinal canal. And then he's going to get complete loss of movement on the side that he's injured. So he's stabbed on the right side. He's not going to be able to move the right side. And he's going to have this loss of vibration and proprioception on the left side. And then you also have loss of pain and temperature on the right. It's super unique, one that we'll probably never ever see, but it is an interesting one to be able to try and talk about. Again, don't touch, or do touch, but don't pull out any type of penetrating injury. Very last case. Call out, somebody's had a high mechanism trauma, they fell off a cliff, and you arrive, they're not moving anything at all. Okay. Take their vitals, they're hypotensive, they're bradycardic, they look flushed, and they feel warm. Talking to you normally, they're not altered. Neurogenic shock, right? And what makes you say neurogenic shock? Right, absolutely. So this is a super unique one, right? Anybody that has hypotension should be tachycardic, right? If we're talking about sepsis or blood loss from hemorrhagic shock, is that they should have some sort of compensatory mechanism to be able to help them out. But this person that's not on beta blockers and they're still bradycardic with their hypotension, I'm a little bit more concerned for neurogenic shock, right? Their body is not producing that compensatory effort to be able to help them out. What causes the flushing and then being warm? Because most people in shock, right, they should be cool and clammy and not feeling great. That's another thing that kind of leads me toward neurogenic shock. So you don't get that sympathetic drive, right? Sympathetic drive causes you to clamp down and increase your blood pressure and increase your heart rate. So these people are peripherally vasodilated, right? They have a vasodilation in the extremities, and that causes blood flow to be able to get closer to the skin, causes them to look red, look flushed, and causes them to be warm, right? So that's why they look a little bit different. They don't look like somebody that's in shock. It's extremely rare. It's a diagnosis of exclusion. So if you get somebody and they're on scene, they had a very high mechanism of trauma, and they have those vital signs, you think neurogenic shock, but you treat otherwise, right? In trauma, hypotension is from blood loss first, right? So you treat this like it's blood loss, and once they get to the hospital, we can deal with everything else, right? So I'm not thinking neurogenic shock until I have absolutely definitively ruled out that he's not hemorrhaging into his belly and that he took, 100 pills of beta blockers beforehand to cause the hypotension, right? So shock and trauma is hemorrhagic first. This is just a unique finding. Again, we talk about the peripheral vasodilation to cause them to look actually well perfused. Diagnosis of exclusion, treat blood loss. Questions, comments, concerns?
The only thing we got from the online audience was one comment about, hey, we used to it used to be adamant that we package up patients with penetrating injuries like gunshot wounds that may have injured the spine, and now it seems to be adamant that we don't. And could you speak to why the change?
Most of it's all data driven as to a lot of people that are packaged up with spinal injuries or just for any sort of problem have long-term problems. If you immobilize, or if you completely immobilize them, there's a higher incidence of further injury and worsening overall outcome. There are many studies that focus on American EMS care versus the last study that I read about this was, I think, in New Zealand, where they don't ever use backboards. And when it comes to spinal injuries, New Zealand has a lot better of I think it's New Zealand. It's somewhere over in Southeast Asia. Yeah. So they have a lot better post-hospital outcomes from their spinal cord injuries than we do here in the United States. It's largely associated with backboard use.
Oh, I'm sorry. Any damage to the cord in a penetrating injury is likely already, the damage has been done in a penetrating trauma. And so further immobilization of the cord isn't really going to help you. And then if you put them on a backboard, they tend to have more problems with bleeding and breathing, and that's why we don't do it.
Yep. I mean, it's something that it's a little bit of a lower risk than like complete immobilization. I think there are decision rules that we can use in order to be able to not have to put patients in C-collars. And I think that using those decision rules are okay. A lot of times in the pre-hospital setting, they're having acute trauma that they have something that makes me say that I can't really clear their C-collar. The area where I'm a little bit, I don't know how Ferg feels, I'm a little bit more lenient about C-collars if somebody needs airway management, is that you can have somebody hold and immobilize the C-spine for you. If you have enough hands, they don't necessarily have to be in a C-collar while you're intubating them at all times, because that's going to, you guys know, causes a lot of problems when you're trying to intubate and you need to manipulate the airway. So I'm a little bit okay with that. Their lack of airway is going to kill them a lot faster than their C-spine injury, right? So that's a little bit more. I would still keep people in C-collars because they can still move around a little bit. It's not a complete restriction.
Yeah, there's a position statement out by the American College of Surgeons, the ER group, and the EMS physician groups that backboards really don't do anything, don't have to do them, and our state protocols kind of went that way. The only people we should be boarding now is blunt trauma and paralyzed. Now you can use a board to get somebody out of the car, down the steps, whatever you got to do, but they shouldn't stay on that long.
Right.
There's pretty good data that C-collars don't do anything either, and they do cause some increased intracranial pressure, those things, but in our state, collars are still going on. The other thing you got to think about is when you see this patient on scene, they're full of adrenaline to pump, right? I've seen guys with busted ankles and legs get out of that car and walk around for a few minutes and they realize, oh, my leg's broke. Now it hurts, right? So C-collar initially is probably reasonable. In our trauma bay at UAB, you're going to get a collar no matter what happens. But if you think about it from a logical standpoint, someone who's not pumped on adrenaline or drunk or intoxicated, if you got a broken bone, you're not going to do something that makes that bone move, right? So if I got a broken arm, I'm not going to do a push-up. I mean, I'm not going to do a push-up anyway. But so if you got a broken neck, you're probably not going to move it. But I hope in the next 5 to 10 years we get away from collars as well.
Yeah.
So great. I had a couple things. One point that you mentioned that was good. He mentioned style anesthesia on back pains or loss of rectal tone. How do y'all check for that in the field? You don't, right? Yeah, I'm not checking that either. Yeah, but the point that he made was risk stratification. So if you got somebody with back pain, and you're going to see patients with back pain, you got to figure out who are at high risk to have bad outcomes. So the IV drug use, or the person who's immunocompromised, the person who can't move their legs, those are high risk patients, and you recognize that, and you move with a purpose on that patient. And then when you get to the hospital, you share that concern with the hospital. Just like your asthmatics, you can have people with asthma that always you take care of, right? But not every asthmatic is super sick. But there's some things you can ask them that make you realize, okay, this patient has a higher risk to decompensate. So the asthmatic who's ever been admitted to the hospital before, the asthmatic who's ever been to the ICU, those are higher risk than your regular asthmatics, right? Just like your people with chest pain and shortness of breath. Okay, if they smoke and they're on birth control pills, they're higher risk for having a PE than the person that doesn't. So that's the purpose of kind of asking questions, getting the history of these people to kind of risk stratify. When do you utilize your resources? At some point in the future, we will be able to screen patients away from the hospitals. We can't now. I'm not saying that. Please don't take that. We'll get in trouble. But at some point, we're going to have to, right? So that's why risk stratification, knowing what question to ask, makes a big thing. The other thing I wanted to mention was on head injuries and CNS injury, a head injury or cord injury. Hypoxia is bad. Hyperventilation is really bad. There's pretty good data out there with the EPIC trial and the EPIC 2 that low blood pressure is bad. I think in the next 5 to 10 years, we're going to see even trauma patients who are bleeding, they're going to get volume resuscitation, but we're going to start seeing some push dose epi and pressures on them to increase blood pressure to keep the brain alive. If your lung is collapsed, your liver shot, the surgeons can fix that. If your brain gets hurt, nobody can do anything with that. So we're going to start seeing more cerebral resuscitation coming. And then I guess the last thing was on you would ask a question and the answer every time I think was the same: airway, right? So if there's a question in EMS or patient care, the answer is airway. all medicine is. All we do in the ER is the ABCDs over and over and over again, and we just add more drugs and tools and diagnostic tests than y'all can do. All they do in the ICU is the ABCDs over and over and over again with more drugs and tools. So if you can manage the ABCs and Ds, then you got it made.
Yeah.
Right.
I'll say neuro overall is a very frustrating subject because the majority of it, we can't do much. But there are a few cases in which, it's like the history is really important in that we can really change our outcomes just by our treatments, like the isonitis, the medication history. When he's talking about blood pressure goals, like when we're talking about we want somebody to be elevated, I want their MAP to be 85 is a general goal. So it's actually, it's pretty high. So it will be important to be able to see how it's managed.
Yeah. Questions, comments, statements within reason? All right, let's take a break. We'll be at.
Very good. Yep. So in November, we'll be at the Alabama EMS conference at Orange Beach. I can't remember the date for that right off the top of my head, but it's a Wednesday. The Wednesday during the EMS conference, and then in December we'll be it's the 9th of November, and then in December we'll be at Springville Fire Department on the 14th. Thank them for agreeing to host. They're always a great host. Thanks to Oxford Fire Department for hosting us here today. It's always a great venue, and to the folks here that helped out at the Civic Center. And of course, thanks to Alabama Fire College for providing our sponsorship.